tissue is relatively loose, allowing for the better blood flow and low risk. Several factors increase the likelihood of skin necrosis. Thicker skin, larger filler volume, use of smaller diameter needles, and injection in highly vascular area. This condition all raise intradermal pressure and the chance of vascular compromise. Now, let's look at filler danger zones. When filler is injected venous thick skin into internal pressure lines, so we must be extremely cautious in this region. If we set the upper eyelid thick as 1, then areas such as the glabella, nasal tip, and chin have a relatively thick skin, and thus a high risk zone. We should also take extra care when injecting near isolated area around the vascular foramina and notches, because these are entry points for important arteries and veins. Vascular obstruction can be divided into two main types: extended necrosis, which occurs when large vascular plexus are affected, and localized caused by occlusion of a small vascular branch. Extended necrosis usually appears with branching redness and spreading pattern, whereas localized necrosis presents a homogeneous redness, localized pattern. Here you can see an example of localized necrosis, a case confined to the nasal tip region. On the right side, a red eschar has already formed, indicating poor prognosis for tissue recovery. In contrast, extended necrosis can usually can spread widely. For example, in the left image, necrosis developed along the lateral nasal artery after nasolabial field injection. In the right image, necrosis spreading along the dorsal nasal artery following nasal filler injection. Both cases clearly shows breaking redness and spreading pattern of necrosis. Other feature of extended necrosis is reactive hyperemia. As blood flow is blocked in one area, the surrounding vessel try to compensate by increased blood flow. This leads to redness or flushing in front of the occlusion entry point. Vascular occlusion can further be divided based on whether artery or veins are affected. Arterial compression versus venous compression. Arterial compression typically present with libido motility and sharp, intense pain. Capillary lipid usually absent, and treatment requires high dose hyaluronic one compression and gel massage. On the other hand, venous compression shows a purple brush discoloration with the gradually worsening pain. In this case, capillary lipid is delayed, and tissue change progress more slowly compared to arterial occlusion. Next, we will look at the 5 progressive stages of vascular occlusion, from early branching to tissue necrosis, and discuss how to recognize and treat each stage effectively. Now, let's move on the 5 progressive stages of vascular occlusion. Recognizing this stage is extremely important because each stage requires different treatment approaching and timing. The 5 stages are parallel, libido, reticularis, post, for coagulation and devitalized tissue or eschar formation. Let's go through each one step by step. First, parallel. The first stage is parallel or skin branching. This occurs immediately after filler injection when blood flow and tissue proportion are suddenly reduced, usually due to arterial blockage. Parallel typically appears within seconds or minutes or injection. It's warning sign that filler might be obstructing an artery. At this stage, we can check capillary repair. If repair is slow or absent, it indicates arterial occlusion. Or repair is fast, it may suggest venous congestion instead. This is a critical moment to act quickly. Inject hyaluronic acid, apply warm compression, and gel massage right away. 2. Libido reticularis. The second stage is libido reticularis, a net-like redness or purplish discoloration of the skin. This pattern appears because of the aneurysm structure of facial blood vessels. When a vascular territory is blocked, adjacent vessel starts showing this reticular pattern due to ischemia in the distal branch. During this stage, vasospasm may also occur, causing collapse of distal vessel and worsening ischemic change. Even if we inject hyaluronic acid and obtain decompression at this stage, slowing or eschar formation may still develop later. So, early intervention, ideal during the parallel stage, is always the goal. 3. Post-formation, bacterial bioburden. The third stage involves post-formation due to bacterial overgrowth. As the sweet gland loses function, the skin pH drops, creating favorable environment for bacterial proliferation. Decompression is essential here, otherwise bacteria can spread deeper into the skin. Interestingly, some patients may still recover where if their regenerative capacity is strong, but in most cases from decompression and proper wound care are crucial. 4. Coagulation stage. The fourth stage is coagulation. Prolonged ischemia lead to cytokine release and platelet aggregation, which not only worsen vascular compression by forming microzombie, but also further reduce proportion around the filler particle. 5. Devitalized tissue eschar formation. Finally, the fifth stage is tissue devitalization, characterized by slowing and eschar formation. This is the result of prolonged ischemia leading to full thickness necrosis. Debridement may be required, but it's best to wait until demarcation. The clear boundary between viable and non-viable tissue is complete. Aggressive or early debridement is not recommended because new blood flow from the wound base is often still developing. In short, patient and gentle wound management are key in this stage. So to summarize this section, understanding which stage you are dealing with is critical to